Well, good evening, everyone. We're so glad that you could all join us tonight. We'll be continuing with part 3 of our series on transcranial photobiomodulation. And as you probably noticed, I'm not Tom, but we still have got a great presentation for you tonight. We're going to have Dr. Margaret Naeser and Anita Saltmarche on, and they're live here to talk about transcranial PBM to treat aphasia and laser acupuncture to treat paralysis brought on by stroke. I've been told to mention that Tom will announce January's winner from the draw next week when he returns. And I've also been told to do a brief demo of our devices. So this is our entry-level, the Palm Professional. It's got the 660 nanometer and the 810. And yeah, it's very portable, easy to treat yourself. We don't have a battery in it, but that's actually a feature because then you can get it on airplanes easier. You don't get stuck at the customs, and it also makes it a whole lot lighter because we thought about adding a battery, but it would just be this big, heavy drill battery that would make it uncomfortable. So yeah, this way you can get lots of power delivery and still in a nice portable shell. And this one here is a step up. It's the Palm Ultimate. It's still got the 660 nanometer and the 810, but this one's got about 25% more power, which allows you to treat in shorter time, and it also can help treat a little deeper. At the top of our range of devices, we have the Super Palm 1050, and it's got the 660, but it also has 1050 nanometer, which you can't see, but we do have a little status LED so that you know when it's on. And this one here can treat much deeper than the Pro and the Ultimate. And yeah, so that's our lineup of Palm devices. We also have a helmet, which fits nicely with the subject of tonight's webinar. This one here comes with 660 nanometer and the 810, and we can make custom the one with 660 and 1050, like the Super Palm. You would just need to get in touch with Tom. His email is tom@sunpowerled.com. And then we also have this mini canopy panel. It's for treating a larger area like your back. And it's got the 660 and the 810 nanometer as well. And it comes on a nice stand, so it's very easy to, put over yourself. Again, for treating larger areas like your whole leg or something. So yeah, with all these prerequisites out of the way, I'm going to turn things over to Anita Saltmarche. Anita, if you can turn your video on.
Okay.
There we go.
Good evening. Thanks, Sam, so much. I have the great pleasure tonight of introducing Dr. Margaret Naeser. Dr. Naeser and I have worked for a number of years together, and although I'm going to go through a very brief bio, one of the most important things is she's an amazing woman, clinician, and researcher. So Dr. Naeser is located at the Boston Veterans Affairs Medical Center and the research professor of neurology at Boston University School of Medicine. Since 2010, she's studied the effect of near-infrared PBM, or photobiomodulation, and the use of LEDs placed over the scalp to treat traumatic brain injury, as well as PTSD, dementia, aphasia associated with stroke, and she'll be talking about that this evening, as well as Gulf War illness. She has a strong interest in neuroplasticity and in the utilization of transcranial, or treating the head, the brain, with photobiomodulation to promote neuromodulation for brain recovery. She's been a licensed acupuncturist in Massachusetts since 1986 and studied laser acupuncture in Shanghai, China in 1985. A wealth of knowledge. She's also co-authored a book, Laser Acupuncture, an introductory textbook for the treatment of pain, paralysis, spasticity, and other disorders. So it's my great pleasure to ask Dr. Naeser to start her presentation, and we're thrilled to hear you talk about all this important information tonight.
Okay, thank you, Anita. Can you hear me? Is that okay?
Yes.
Okay, great. Now, yes, I do have two topics tonight, and I'm going to try to get through both of them pretty fast because Anita, assuming we have time, will talk about some of her experience with treating stroke patients, adults and children, at the end. So we'll see how far we can get. And we are willing to go over by a half hour if there are questions and we need to go beyond 8 o'clock. So I do have two topics, transcranial photobiomodulation to treat aphasia, which is loss of language due to brain damage, usually on the left side of the brain, often from a stroke, but it could also be from a tumor that is there, something like that. It can occur in adults and in children. And the second part is laser acupuncture to treat paralysis and stroke. And these are my wonderful collaborators all over Boston. And we don't have any conflicts of interest. A lot of our research with transcranial photobiomodulation has been sponsored and paid for by V-Light and Thor Photomedicine. We don't really have any conflicts of interest. So as Sam mentioned in the beginning, we did a session. The first part of all of this was laser basics. And when we did traumatic brain injury, including PTSD, then the next Tuesday, we did football players with possible CTE. And we talked about dementia because Anita Saltmarche has a lot of experience with treating that. And tonight, I'm going to be talking about aphasia, which is loss of language due to brain damage, and also laser acupuncture to treat paralysis and stroke. I'm going to just spend a few minutes, not long at all, reviewing what we went over from the beginning on what are laser LED basics. And, you know, if you can remember back why we work with which wavelengths, we've got red wavelengths that you can see. And here's the visible spectrum from 400 nanometers violet up to red in the 600 and 700s range. But those shorter wavelengths are only going to penetrate about a millimeter. Then we also work with longer wavelengths that are 800 nanometers and higher, and they're going to have a greater depth of penetration even through the forehead and the scalp into the brain. It can be 1 or 2 centimeters or 4 or 5 with the more recent, but you lose a lot of energy the deeper you go. So really only about 2% or even less of that of the photons you deliver on the surface of the scalp or the skin is going to make it to surface brain cortex. So whatever you're putting on out here is not necessarily going to make it all the way to the brain. And we don't go much lower than 600 nanometers in this lower corner diagram because the hemoglobin in the blood will start to block up, but then it can be a good way to also treat the blood. But we won't be talking about that tonight. And we don't go above 1,000 nanometers because the water starts to block the penetration. Okay. Now, in review, there's going to be a greater increase of ATP, adenosine triphosphate, the battery pack for cellular respiration, in hypoxic cells, those that are low on oxygen. They're stressed cells. And you can see here in these graphs down here, this low white bar here is the hypoxic low oxygen cells, and the normal ones are in the dark gray. And then after exposure to near infrared light, 810 nanometers, you can see here on the right graph that the low oxygen cells, took that in, the near infrared light, and they increased their ATP production 6-fold. But the normal cells that were normal in oxygen to begin with, they only increased the ATP by 2-fold. So it's really the stressed cells or damaged cells that can really take in the photons and work with them. And you saw this last week. We have the electron transport chain here, and this cytochrome C oxidase is sort of here towards the end. And in a stressed hypoxic cell, the cytochrome C oxidase up here is blocked. It's absorbed by nitric oxide. Okay. Now, and the cell is the mitochondria in the cell are not doing well. There's very little ATP production and low respiration in the cell. But you apply red or near infrared, 810 nanometer, for example, and the red is in the 600s, to the cell, and very quickly the nitric oxide goes outside the cell wall. This is a generic cell. The white perimeter here is just showing that it's going to come outside. The nitric oxide is going to diffuse to the outside of the cell, and that's going to increase blood vasodilation as well as the lymphatic vessels, which is very important to drain waste products and whatnot, and it will decrease swelling. Very quickly on the left side here, you can see these are cellular effects. So we just reviewed increasing ATP, especially in low oxygen cells. We're going to promote vasodilation in blood and lymphatic vessels. And we're going to get neurotransmitter release, serotonin, that'll reduce pain. And you'll get brain-derived neurotrophic factor if you're doing this on the brain, which is very good to help the neurons for regeneration and recovery, for example. And you get increase in synapsin, so the synapses will work better. And then there's antioxidant and anti-inflammatory effects, but we don't have time to get into all those mechanisms today. So part 5, transcranial photobiomodulation to treat aphasia, loss of language. This is going to be after stroke. And when I say loss of language, it goes across all modalities of the language. It's speech output, and it's language comprehension, and it's reading, and it's writing. And many different types of aphasia exist depending on where in the brain the damage is located. We won't get into a lot of that detail tonight either, but I just wanted you to know there's a range of types of language problems and of severity. And so this paper following where we worked with transcranial photobiomodulation was published in 2020. I'm giving you the answer to the research project before we get into it, because the answer is, where do you want to put your LEDs and your transcranial photobiomodulation? And it turns out you really only treat the same side where the stroke occurred. So if they're aphasic, it's 90% of the time the problem's in the left side of the brain. And then we want to treat 2 midline nodes of the default mode network, if you remember that from before, in the front here at the hairline, mesial prefrontal, and then high in the parietal lobe back here, precuneus. But I'm going to take you on our trip or journey here. How do we figure this out? Well, it's by trial and error, I can assure you that. So we studied 4 different placement protocols. And every time we got a new protocol we had to work with, they were treated 3 times a week for 6 weeks. It's our usual protocol. And then we tested them on their language 1 week, 1 month, and 2 months after the 18th treatment. And we were really just trying to see if we could improve their word recall for naming objects especially. And we did some MRI imaging as well. So the chronic aphasia patients came into the study at 2 years or 18 years after their stroke onset. So they were very stable in their aphasia and language ability or disability, however you want to look at it. And they were just wonderful to work with. And 5 of the 6 cases were greater than 10 years after the stroke. So they were very, very stable. And they all had lesions on the left side of the brain. And you can see on this one at the top, we have labeled the left side with an L. And this dark black area here is the area of brain damage after a stroke. It fills up eventually with cerebrospinal fluid, a liquid. And there it is, and it stays there. There's no neurons in there, I can assure you of that. And then you go all the way to the top, and this is getting closer to the top of the brain. Oh, I'm sorry, this is the first case going all the way up, and the second case, and so on. And all the lesions are in the left hemisphere. I wanted to point out patient 5, a very rare type of aphasia. It's called word deafness. And the patient hears words as sort of gibberish and can't understand anything you're saying, but can read and write. And the problem is, normally if you have word deafness, which is rare enough, But in those cases, you would have lesion, brain lesion in the left side and the right side of the temporal lobes, both sides. So the auditory processing is very difficult and confusing for the patient. But in this unique case down here, patient 5, the issue is that in this 1, 2, 3, 4th one from the left here on the left side, the lesion goes all the way against something called the body of the lateral ventricle in the brain. And the pathways coming over from the right temporal lobe can't get there to the left side to understand language or any auditory input really that's meaningful from the right side of the brain, the right temporal lobe. So we have a unilateral lesion, one meaning on one side only here on the left, but it's a bilateral auditory problem because those pathways are blocked off. It's very rare. Okay, so protocol A, we'll start with that. We're going to go all the way A, B, C, D. And we just thought, oh, this is 2011, by the way, it's very early. And we said, well, we were doing pretty well with traumatic brain injury, so we'll just put these LEDs all over the head in the stroke patient. Boy, were we wrong. But here it is. You put the LED cluster head and hold it in place with a stocking cap. But you're going to see very soon, I'll show you the results here, that naming was not improved. Now what happened? So here's our first patient, and he's a good example here. Protocol A. We're going to put the LEDs all over the head, down the middle, and everything. And now I wanted to show you how to look at this. You're looking right over here in this upper left-hand corner to the right side of the brain, and the right eye would be right here, the eyeball right here. And then this is the left side of the brain. And look at we have a large lesion there, but some parts are spared. And then the left eye is under here. So you're looking into the side of the head. All right, so now we're going to treat Monday, Wednesday, Friday, both sides of the head. And here's the results for patient 1, 18 years post left hemisphere stroke. Well, look at this. It's pretty bad. Nothing improved. His naming did not improve at all. Percent change from baseline is even below, so he got worse at 1 month testing. Well, good grief, what happened? Well, if you come back up to the brain imaging here, remember, we put the LEDs all over the left side, right side, down the middle, just like a TBI case, but this was not a good thing to do here. So we got even more overactivation, as we would call it, in the right side of the brain. You really don't want to see that, actually, because it means the right side is trying too hard and things are disorganized. And then on the left side, the good news was we got some new activation. He's trying to name pictures in the MRI scanner. This is good. We want to see more activation on the left side here. And we got activation in what we call the supplementary motor area on the left side. But the bad news is we got it also on the right side, supplementary motor area. And over here on the right, I have a diagram for you. How did we manage to do this? Get all this activation in the right in the left supplementary motor area and the right. Well, we put one single LED cluster head at the top of the head. And the supplementary motor areas are located right there. And what we ended up doing was confusing the heck out of the brain, because when people stutter, the left supplementary motor area and the right supplementary motor area are in competition with each other. And you normally only have the left supplementary motor area more active when we need to talk, because we got to get the left hemisphere motor pathways going. But when people stutter, they actually have equal activation in the right supplementary motor area and the left at the same time. And that's what we did to our stroke patients with aphasia by treating one LED cluster head at the top of their heads. And I was just going to show you here what this looks like. That's the size of it. So you can see if you put it at the very top of the head, it's going to get the left side of the brain up there and the right at the same time. So controls, normal people, only activate the left supplementary motor area, this red area here. But people who stutter are doing the left and the right at the same time. And that's why they have this stuttering and have problems with getting speech out. So what we learned from protocol A is do not treat the top high part of the brain, because you're going to get the left and right supplementary motor areas at the same time. And please don't treat the right side either. So don't do it bilateral. So that was pretty bad. So moving on to protocol B, we're going to treat the left side of the brain only, because we know language is on the left side of the brain, and that's where the actual brain damage and stroke located. Okay, so we're going to treat just the left side here. We're not going to get carried away and treat the top or anything like that. It's just the left side. And that works very well. So here to the right is protocol B. We treat the left side only where the stroke is. It's the same patient, by the way, how patient he was with us, I'll tell you that. And we do improve naming. It's a really beautiful, I think these are beautiful to see. You come down here and you can see after the left hemisphere was treated only, the percent change is significant at 1 month, where it was significantly worse at 1 month over here on the left when we treated both sides of the head and the top. So we have a beautiful functional MRI here. He's naming pictures. And, you know, you see here on the left, this nice new activation in some of the left side that's spared, no lesion there. That's a good sign. And we have activation, this little red dot here, in the left supplementary motor area. And look, wonderful. No activation in the right supplementary motor area. So this is a really good treatment. And we had the same results with our second case, patient 2. All right, we got that taken care of. And then we went to protocol C, and we said, oh, let's see if we start to put in the default mode network, and we just do another LED at the high forehead. And we only applied 13 joules per cm square instead of above 30 or down at 26. And that was not great, only a moderate or poor response. So then let's go on to protocol D, and we're going to treat the left side of the head, nothing at the top of the head, but we're going to try for 2 nodes of the default mode network, and we're going to get a really good response and significant improvement. And you remember the default mode network, we talked about that a lot when we were talking about dementia particularly. So now we're going to add just these 2 top midline placements, but not at the vertex. We don't want supplementary motor area to confuse the brain. But we're going to help the default mode network in a way, because the default mode network must down-regulate, if you remember that from before, down-regulate, get out of the way, and allow language to take place, or executive function. And here we're interested in language in the left hemisphere. It's really down in here. That's the main main language area, sort of deep from the ear. So we have optimal protocol D, and that protocol, we treat 2 nodes on the default mode network, mesial prefrontal up here at the front hairline. You can't see it because this is the left view of the brain only. And also back here at the high parietal precuneus. And so now we get our very best results. And this can be done at home. We just have to train the patient how to do it. And this is some brain imaging. This is a P6 chronic stroke aphasia case, good response. And treated with protocol D, 26 joules per cm square, left hemisphere, plus 2 midline nodes in the default mode network. And you can see that this is before here, this whole image here on the left of this sort of double image here it's before the treatment. Yes, the mesial prefrontal cortex is doing something, but it's not really communicating with the part further back in the high parietal lobe. And then at 2 months after the 18th LED treatment, protocol D, now we finally see some good communication between the mesial prefrontal cortex here in the front, just behind the forehead up at the hairline, and then precuneus is back here. And they're on the midline. And now we have significant improvement in naming ability. Actually 1 week, 1 month, and 2 months on 2 different naming tests. So that was good for this, very helpful for this patient. Now, we also wanted to study what their elicited spontaneous speech is, how well can they describe a picture. And there's a picture pretty famous called the cookie theft picture description in the Boston diagnostic aphasia exam. And this is very impressive what happened with this patient who's non-fluent. He's still patient one. The baseline mean, the number of verbs he could use, I have it at the bottom of the screen here, was only 6. And then, of course, we treated him Monday, Wednesday, Friday, 6 weeks, and protocol D. And not much change 1 week later, only 6 different verbs. But look at this, 1 month later, oh, now he has 9 different verbs. And at 2 months after the 18 LED treatments had ended, he's got 11 different verbs to describe that picture. I think it does take time for the brain to reorganize after you give it the photons and you put them in the proper places. I think that just takes time. I think that's true almost in all of these cases. Okay, so now this is the first slide I showed you in this part of the talk. The answer to what are you going to put your LEDs to treat aphasia after stroke is treat only the same side where the stroke occurred. So aphasia is 90% of the time left hemisphere, and two midline nodes of the default mode network. Now, there was another paper published in 2023 on using transcranial photobiomodulation to treat aphasia. And this is a really interesting study. I thought it was well done. And the speech pathologist, there's only one case, but she started treating the patient only like a month after stroke onset, so well within spontaneous recovery. And the patient didn't have that much change. But then after that was over with, she started treating the left side of the head, the left language areas only, and she did light emitting diodes, red and near infrared. And then that was the first part of a speech therapy session, but she wasn't doing any speech therapy then because she's holding this LED close to her head on the left side of the head. And then she got a helmet and she treated both sides of the head. Now, I think she primed the left hemisphere for language, because that's where she treated first. But then she treated both sides of the head with this helmet during speech therapy. So the patient's theoretically using the left hemisphere during that helmet treatment. And the patient improved tremendously. It's really amazing if you can read that paper. And if you write to Tom Kerber, I can send it to you. It was very impressive what happened when you combine speech therapy with the language protocol. For treating with a transcranial photobiomodulation. And this is an application of treating the left hemisphere for language in children with language problems, including autism spectrum. So they would use the same basic language areas that we mentioned during what I listed here. And there's a study going on in New York City with Eugenia Steingold. And there's a pediatrician doing this with her from Robert Wood Johnson School of Medicine. And this is for children ages 2 to 6 years old who are nonverbal. And they have less than 10 words. So she'll be publishing that paper fairly soon. We hope Anita and I are co-authors on it. But I think it's a wonderful thing to do. And the children are very happy to wear this little sort of circular halo thing around their head, but it's only treating the left side for language. And this is a study with adults who were very acute stroke patients in a hospital, and it's within 24 hours of the stroke onset. And unfortunately, their protocol was to treat both sides of the head. And it's so sad because they didn't have brain imaging and they didn't understand what was going on. Their first pilot studies seemed to be promising, but by the time they got to phase 3, clinical trial was canceled for non-significant results because they kept treating them both. They only got one treatment. That's a problem. The patient only got one treatment within 24 hours, but it was to both sides of the head. So you can imagine the confusion that's going on if they had language problems. But they were studying everything: paralysis, comprehension, there was a general NIH, National Institutes of Health stroke severity scale. So it took in all kinds of things. And when it was all said and done, their large scale studies didn't work, but I think it's because they were treating both sides of the head. Interestingly enough, they never treated on the midline. Actually, probably pretty good because they would have made it really bad if they'd done the top center, I guess. But they were treating both sides, and that's a problem when you only have a stroke on one side. So now we'll go to part 6 of my 6 parts that I've been going on for 3 weeks here. And this is laser acupuncture. And I know in America, nobody ever heard of this. And I didn't know anything about it either. But there was a very nice woman, ear, nose, and throat surgeon from Shanghai, China. She was in Boston. Well, she was at MIT in Cambridge getting a master's degree in laser medical physics, because in China, they were doing a lot of work with lasers. Basically, in the 1970s, they got a lot of information from the Russians. The Russians had influence there. So, and you may or may not know that it was 1967. This is behind the Iron Curtain, that in Budapest, Hungary, they had, Andre Mester, the ear, nose, and throat surgeon there, had discovered that you could, by accident, that you could use red beam light to grow hair, especially on the backs of mice and this sort of thing. So it was an accidental finding. And then the Russians, this is still behind the Iron Curtain, they learned about lasers and the therapeutic benefits of lasers. And then because the Russians had influence in China after Mao Zedong died in 1967, in the early 1970s, the Chinese got this idea, I gather, from the Russians and from Budapest, Hungary, that you could use it beneficially. Now I'm there in 1985. So I arrived because Dr. Wei Shubing, the laser acupuncture teacher who was ear, nose, and throat surgeon at MIT in 1984, taught a 3-day weekend workshop. And I said, wow, that sounds interesting, because I just finished acupuncture school in 1983. I said, oh, let's go. I'll go see what I can learn. And there were only 5 people who showed up, and the New England School of Acupuncture wanted to cancel it, not enough people. And she says, oh, no matter the money, the people in America need to learn about this. And that was good. So I went, and it was great. And then she wanted to know why all these people, why are you here in this class? I said, well, I'm studying stroke and the brain. And she said, great, you have to go to Shanghai, China. My husband is chief of neurosurgery, Shanghai #1 Medical College. We'll get you a visa, and you have to learn this in China. I said, okay, that sounds good. So 1985, a year later, I lived in Shanghai, China for 2 months. And this is what the hospital looked like then, and now it's a high rise. You know, you can imagine there's just skyscrapers all over Shanghai now, but this is almost 40 years ago. And so the first floor was dermatology. I learned how to grow hair, and now growing hair with red light is all over the internet. So, but the Chinese were doing it in 1985. And on the second floor was neurology. So there I'd go every day and watch the acupuncturists treat paralysis and stroke with lasers. And here's our first patient. Here's the red beam laser light. That's all they had was red. They did not have near infrared. And treating an acupuncture point here, large intestine 11 on the arm. He had had a hemorrhage on the left side of his brain in the thalamus. And if it's a hemorrhage and there's active bleeding, we do not treat, because we don't want to vasodilate. But after the hemorrhaging is stopped and the clots resorbed and so on, then it's very safe. They usually waited 2 weeks to treat. And he did well. So I came back and started working with this at the Boston VA Medical Center. And we published a paper in 1995, 10 years later. And it is very helpful. And it's just another way to treat the acupuncture points, which are decreased resistance, therefore greater electrical conductivity. And they've been around for, known for over 2,000 years, and their basic anatomical loci are the same. Mostly, in animals, mammals, etc. They're just a biomagnetic electrical field system where there's decreased resistance when you get to an acupuncture point on a meridian. And so they're put together. It's a really fascinating topic. So there's many laser acupuncture devices on the market, and they'll have an aperture of about a beam spot size of 1 centimeter, and you can get them smaller. And you just put it right over the acupuncture point down here in the right-hand corner. You can see that. And instead of the needle, you use the laser instead of the needle to activate the acupuncture point. So we worked with 7 stroke patients, and they were ages 48 to 71 years when treated. They had 2 cases had single left hemisphere stroke and 2 right hemisphere. We were not studying language in the brain at this point. We're just studying paralysis. So, okay. Now, it turns out that when you're trying to treat paralysis, you really have to make a distinction. Are you working with an arm and leg, upper extremity, lower extremity paralysis, which is often more severe, that's more involved? Or are you working with a patient who only has hand paralysis? Basically the proximal arm and the leg are pretty good, but it's the hand, they can't. But they have some flicker of movement in the hand. And so that's a really good sign, but they're clumsy. So we have to separate the hand cases from those who have the arm and the leg involvement. And then you'll see that makes a difference in what the results are. So 6 of the patients were treated in the chronic phase after 10 months to 6.5 years after stroke onset. That's beyond spontaneous recovery period, which is usually 3 to 6 months. And then one patient was treated during the acute phase at 1 month post-stroke. So, but most were in the chronic. And at that time, you're talking 1980, really 84, and that's when I started using the laser acupuncture, and then after I got back from China a little more. So 84, 85, 86. And the only lasers we could get were from Denmark. And we had 780 nanometer near infrared. It had a 1 millimeter diameter aperture, so that's really handy to get on an acupuncture point. And all we could do on shallow acupuncture points, hold it for 20 seconds, but the deeper points, we didn't have near infrared, so we just held it there longer. Who knows if we were really treating deeper acupuncture points. And I'm not going to go through them. They're listed here and they're in the published paper. So as usual, we treated 2 or 3 times a week, but because some were outpatient and so on in their homes is where we had to go to treat them. It took 3 or 4 months per case. And we ended up giving, because we had no idea if it's going to work at all, 20, 40, or 60 treatments. And the testing was blind, done blind by the physical therapists and occupational therapists, the wonderful ones we worked with at the Boston VA Medical Center. And they never knew if a patient came and we asked them to test them, were they receiving laser acupuncture or real or sham needle acupuncture or no acupuncture, because we had some stroke cases who were receiving none. So this is our results for one of our patients. He's 54 years old, and across the horizontal axis down here is on this x-axis is the months post-stroke onset, when all these different things were done with him. We had sham needle. I won't go into all that. You treat the good side, not the paralyzed side. And then we did real needle acupuncture, and then we did no treatment. And a year after stroke onset, we started in with the laser acupuncture. And he actually received 20, 40, and 60 laser acupuncture treatments. And you can see he got to 60%. On this y-axis here, this vertical axis, it's percent active range of motion. And this test was for knee flexion, or just bending the knee. And he got to 60% on ability to bend his right knee. And that was the best he'd had in over a year. So I think that the lasers were very helpful for him. And then also same patient, shoulder abduction, which is, lifting the shoulder out here from the side. And he got 100% on that after the laser acupuncture was started a year later. But it took took a while. You have to treat really here. This was after 40 treatments and 60. So it can take time. You just want to be patient with all of this. And this is another patient. This is a woman. And she has a little bit more extensive stroke. But what's interesting is if you look, this, I'm going to go through a little anatomy. I'll show you that in a minute. But this is lower in the brain. Okay. And here's her stroke on the left side of her brain. And this is the front up here towards the front. And then you're higher in the brain. You can see the skull is smaller in diameter here. But this part right here is what's really important to look at regarding her lesion. And the arm pathways are sort of more anterior here towards the front, but the leg is more posterior. It's sort of a way of looking at it. And she only improved on the leg, not on the arm or the hand. So this is why it was handy. We could actually, we're at a VA hospital and we could get brain CT scans. And this helped us tremendously in understanding our patients and who benefited and who did not from the acupuncture or laser acupuncture, but I'm just going into laser tonight. So she was treated with the laser at a year after stroke onset, and she had improvement there. And again, on knee extension. So this is putting the leg out straight. And of course, the knee flexion is bending at the knee. But she only improved in the lower extremity. Now, this is the anatomy I wanted to show you very briefly. It gets kind of complicated, but this up here in the upper left-hand corner, you're looking at the left side of the head. So the left side here. And you have a motor cortex and a sensory cortex. And so out here in the front, this would be the left eyeball would be down here. Okay. And then the language areas, we went over that, are coming right along here, the Sylvian fissure. And we treated those with the transcranial method. But now we're on laser acupuncture. And so it turns out that when you slice through the brain this way, we call it coronal, like slicing through bread, you can look at it from the front, looking in, and you can see all these pathways are going to collect right here. That's for the face and the hand and the arm and the leg. They're all going to collect in this part we call posterior limb internal capsule. But up here, where they're really just coming in, is the most critical place to look for the lesion location. And as down here on the left, you see this slice with, it kind of looks like two bananas or, crescents. And over here on the right, you can see these are labeled anterior, middle, posterior. It's the white matter pathways. It's these pathways collecting here in this periventricular white matter. And then they go down into the posterior limb. The deeper you go in the brain, the more compact the fibers are pressed together. So if you get a deeper lesion, deep, oh my, you're getting so many pathways all at once. It's really a problem. And so that's really bad if the lesion's right next to the body, the lateral ventricle here, or in the posterior limb there. So we learned that really severe cases, we really couldn't help them. We only helped overall about 66% of our stroke patients with paralysis because the lesions were just too deep for the arm, the leg, and so on. Now, this is a patient, 48-year-old woman, 4 years post-stroke, and her stroke, you can look over here. The stroke is on the right side of her brain. Okay. And now you come to these crescent-shaped levels, and she's got a lot of lesion right next to that body of lateral ventricle. And she had poor response for the arm and the leg. But the laser treatments, laser acupuncture, did loosen the Achilles tendon, and that was easier for her to walk. But she had really good results for her face. She kind of got a facelift. So her left side was dragging, and she had food that would come out the left side of her mouth when she was eating. This was going on for 4 years. And wow, after 9 treatments, her face lifted on the left, and she was able to keep food in her mouth. It started even after only 5 laser acupuncture treatments on the face that she could control food and liquid. So she was very, very happy. So overall, the results, 5 out of 7 of the cases, 71% improved. 3 out of the 5 patients with arm leg paralysis improved, had good response, but 2 didn't improve in arm leg. Their range of motions for those who did improve, 11 to 28% increase, remember knee flexion and knee extension and or shoulder abduction. So those were the main tests for the arm leg cases where there was improvement. In the patients who had hand paralysis, there were 2 of those. And they had a lot of improvement in grip strength on the hand and tip pinch and all these hand dexterity tests and strength tests. So they did improve. And it's very important to know, does your patient have any connection? You know, you ask them, can you move your fingers or 2 fingers? If they have any flicker of movement, that's a really good sign because there's still a connection between the hand and the brain. But if it's a dead limb or flaccid, it's really, really hard to treat them. Now I want to quickly go through the hand treatment protocol. I call it the Naeser Laser home treatment program for the hand. And I wanted to mention it's very helpful for stroke patients, for hand problems, but also spinal cord injury. You can help reduce some spasticity there. And you may have heard on the news that the singer Celine Dion, I think her name is, in Montreal, Canada, has stiff person syndrome for 1 year, and she's been told there's no treatments for that. Wait a minute, I treated a case of that with laser acupuncture, and I'm sure you could do it with light emitting diodes, probably Tom Kerber's, handheld palm, one of those devices. I think you can relax those muscle spasms. And also locked-in syndrome can be very severe stroke. Everybody said you can't treat this, but I went there to the nursing home, and within 24 hours, she was much more alert. So think of this. When somebody tells you it cannot be treated, they haven't tried photobiomodulation. At least that's my experience. So quickly, we're going to go through treating this hand treatment program. And you put the laser on these special acupuncture points at the base of the fingernail beds, and you use microcurrent on the wrist and in the palm of the hand. And we like to do microcurrent because it's going to increase ATP. We always want to increase ATP. Current in microamps up here. So then you do not want to feel anything that when you're being treated with microcurrent, keep it subthreshold. But when you get up here to milliamps, and physical therapists like to turn it up if they're treating that. Milliamps tends to, divert pain pathways and reduce muscle spasms, especially in the back. Well, it goes down. You're not bringing ATP in there. At least in our experience and studies that we've read, you want to keep it subthreshold. So this is the protocol: acupuncture, treat, red beam, laser, or you could do LEDs, I think, also on the base of the fingernails. This is the stroke patient. She came up from Philadelphia. She was 1.5 years post-stroke. Her hand is what we call fisted flexion. It's curved in and that. And so we went through the protocol, and here in the lower right-hand corner, 20 minutes later, her hand is open. Now, she did not have that for 1.5 years. And I know that the hand will respond very well to red light and red and near infrared as well. But this is a treatment program that can be done by patients at home. And this is treating a very young woman in her mid-20s who had had a stroke on the right side. And she's just using a lecture pointer. This black pointer here in the middle is a laser lecture pointer. And this was her in the upper left-hand corner, her fisted hand in flexion, and then before treatment, and this is 20 minutes later. And they can do this at home, and you get much better results long-term. And another patient, the hand this happens to be a left hand, it's fisted flexion, and then 20 minutes later, it's open. So we also can treat the foot with the same type of protocol. This is a spinal cord injury case, and so he's treating these special acupuncture points at the base of the toenail beds, again with a lecture pointer, laser lecture pointer. And he had less spasticity and clonus after that. This is a study done in Austria with laser acupuncture of the foot in humans. And it's just amazing. So this is the right foot. And you're going to put the red beam laser right here, an acupuncture point called bladder 67. We're going to do this in the MRI scanner. And instantly, you see in the right occipital cortex activation, because This point down here on the fifth toe is number 67 on the bladder meridian. It's a very long meridian, longest one. Comes up the back a couple times, comes over the head, comes down, and ends up in the medial canthus of the eye. And you can use points right down here on the foot to treat eye disorders. So, but the thing that was amazing, it happened instantly. Maybe speed of light, I have no idea. So it says we only elicited ipsilateral, meaning same side, brain activation within brain cortex, lacking any contralateral component, which is the way sort of the visual system is put together, right visual field left and all that. So it's very different. The acupuncture meridians have their own system. This is quickly cerebral palsy, paralysis in babies and children, hypoxic at birth. And this study was done in Japan, and they consider laser therapy to be a reliable, non-invasive, painless way of reducing spasticity. And this is just a child in Boston working, trying to work with it. He was a little old to get started. I think he was 4 or 5 years old. It's better to work with babies even 2 weeks post-birth if they were hypoxic at birth. And this is this home treatment program for children with cerebral palsy and motor development delay. And it's in my acupuncture textbook, and it's all spelled out there. And you can get that from OMS.com. I don't sell them. This is in Austria, Vienna, Austria, treating deaf children with red beam laser because that will help their articulation when you can get them, to try to talk, and they will. And it's very safe to do with children. And one last slide here is Bell's palsy. You wake up in the morning and there's paralysis, on one side of the face. It's probably a virus. A lot of inflammation there, but acupuncture or laser acupuncture is 100% successful to treat that paralysis in the face if you can get it in the first 3 days. And this is day 1. The patient came in the clinic. This is in Shanghai, and he couldn't close his right eye because the superior division of this facial nerve was involved. And then immediately after needle acupuncture, you can see down here his right eye is closed, and you can do that with laser acupuncture. This is just really interesting. Other method that chiropractors use, waving the laser back and forth, but she had right biceps contracture due to stroke, arm is flexed up here. And it took a half hour, but he got it down. So these are just his diagrams. Okay, so now we quickly move on to Anita, who has really nice stories, I'm sure anecdotal, treating these cases. Thank you. And
thanks, Dr. Naeser. So I'm a bit torn, but I'm going to be very quick about this. I'm just going to talk about.
We can go over too.
Yes, and we can go over, and I think we also have a few questions. So,
right.
Again, I've worked for a long time with Dr. Naeser and learned the language protocol from her, and we've used this on a number of individuals. But I'm going to tell you about a 72-year-old woman had a stroke. And I was not looking at the paralysis. We were looking specifically at speech and language and communication in general. And at that point was really, nonverbal, was not responding. And if she gave an indication of, a yes or no, it was often incorrect for what she was really asking for. So we started the language protocol, and as Dr. Naeser said, 3 times a week. And at this point in time, it took about 12 weeks. She was 3 years post-stroke when we started this. And over probably 6 months of treatment. So I work with families and individuals virtually. So all of them are, depending on what they need, devices are recommended, and their treatment is supervised at home, and they learn how to do their own treatment. So they purchase devices, they were using the language protocol, and over time, she gained not only nouns, but verbs, and was able to put very short sentences together, but she was much more interactive. She was correct in what she was really trying to communicate as her wishes and what she wanted. She was able to communicate with her children and her grandchildren, which was wonderful. And she even started to get her sense of humor back, which was something that didn't happen. So that was, and her sleep improved and she was much less anxious. So all in all, I probably worked with them for over a year in total. Not consistently, they would make some progress and then we would change your protocol slightly, but she did improve and it was really terrific to see. And as Dr. Naeser was talking about, certainly children, and I've treated anything from infants just a few weeks old, and most of them have had hypoxic or ischemic events. So either in the birthing process, there's a lack of oxygen to the brain, oxygen and nutrients, and so there's damage to the brain. And many of these infants suffer from seizures and have seizures on coming home. And I treated a young girl who was having up to 21 seizures a day. And in fact, we got her to a point where she hadn't had a seizure in 2 months. So that was pretty amazing. As well, many of them, from a cognitive and functional perspective, do not develop. So we also used the developmental protocol that Dr. Naeser was talking about. And she started to, with other therapies. So almost never do I interact, and I'm sure Dr. Naeser's been in a similar situation where, whether it's traumatic brain injury, a child with hypoxia, a child with autism, PTSD, they're often using other treatment strategies at the same time. But many of them have been doing this for quite some time. So this young child was at that time getting physical therapy and a number of other therapies, because at that point she really wasn't meeting any of her developmental milestones at that point in time. So she did start to roll, she did start to develop, and within a 6-month period that I was working with her, there were a number of improvements. Language was too young at that point, so that's not what we were looking at. She was also having difficulty sucking and feeding properly, and that improved as well. So there are a number of different areas we can treat depending on what the issues are. So whether it's transcranial, using developmental acupuncture points. So it's just to show you the breadth and what is possible in using light energy if the correct protocols are being used. And I think Dr. Naeser's example of the learning process involved to come up with the correct protocol for treatment for someone for aphasia, which is different than when we treat traumatic brain injury. So, and again, depending on the condition and other circumstances, the light therapy can be amazingly effective, but much more so if you have correct protocols. So I don't know, Dr. Naeser, if you'd like to come back on. I think I'm going to leave it at that rather than go to another one. And we can also talk about some of the questions that have come up. So one of the questions is, an individual is a 52-year-old woman, female, recently diagnosed with MS, and wondering if there are any effects with PBM in reducing lesion growth. So I don't know if you want to talk about some, and I don't know about the lesion growth, but we have had some experience with MS and progression in general.
Can you hear me?
Yes, yes.
Okay. I don't have experience with multiple sclerosis. I really don't. You would think it could be helpful because of the anti-inflammatory effect from the light emitting diodes. But if you have experience, then that's great. Anita, you should explain what you've observed.
Okay, so I have worked with individuals with MS. There is, Dr. Lyons has done some work in this area for sure. And whether or not you're in remission and the type of MS, appears to make a difference. So I think that would be something that would probably be more appropriate to talk about on a one-on-one basis, as opposed to trying to talk about the different protocols and what would be, possibly done with that. There's another question about someone who had
Anita, I did want to say something about
yes,
about
please.
MS.
Yeah.
I just remembered. I haven't. Well, it was with another acupuncturist in Massachusetts. He's down in sort of the southeastern part of the state, and he did have someone come to him who had MS, and he did say it was helpful. And he had a laser, and he was using mostly on the body, the arm, or wherever the problems were located.
Okay.
Different for different people, and it was helpful. So
Okay.
I just throw that in.
Yeah, no, and that's great.
He treated with a laser, and he treated it as if it was a paralysis due to stroke. I mean, it was a similar protocol, but it was on both sides. He treated both sides.
Okay.
Sorry. Now, what's the next question?
The next one is, what is the treatment for a patient who had a stroke on the right side rather than the left side?
That's the same as if it was the left side, regarding where you want to treat, where you want to put your LEDs and your cluster heads. You want to treat, if it's on the right side, you treat the right side of the brain and the hemisphere. And you can still treat the mesial prefrontal cortex and hyperparietal precuneus on the default mode network. You can do that. I would not put it at the vertex. I still wouldn't do that. But I really don't know. I haven't worked with protocol A anymore after I sort of finally fixed my first two patients. But it could have something to do with the fact that it was a dominant hemisphere stroke, the language in the left and all of that. But it should be the same for treating the right side. And I did show you one patient who had lesion on the right and paralysis on the left. Her arm and leg paralysis was too severe for the most part on the left, but her face improved. And so, yeah, you can apply the same principles.
Okay, good. There's a question here from Dr. Barbara Zedler, and what is the typical duration of the long-term daily or multiple times weekly transcranial home treatments?
Is that how long does it take to do it?
I think that, and how long do these actually, so typically the duration of long-term daily or multiple times weekly. So how long would you continue to treat, I think, is part of that question for home treatment. And I think it really depends on the type of condition you're treating, right? So.
Oh, yeah. I'm just trying to pull this question up here.
Yeah. What's the typical duration of the long-term daily or multiple times weekly transcranial home treatment? So
it depends on the device and really what you're treating. With the helmet, the Tom Kerber's SunPowerLED helmet, that's 4 minutes. You can treat the whole head in 4 minutes. It's a 1 minute red and 3 minutes near infrared. And you can turn on and off the different LED clusters he's got around the head. So, I mean, I don't really know I don't know if I understand the question completely, to be honest.
I think it's how long do these treatments actually go on? So I think for traumatic brain injury, although it's a single injury rather than a progressive injury or a progressive condition like Alzheimer's or Parkinson's, even then, I certainly have had individuals who have gone on to, they've been treating 3 times a week. They may have treated 16, 18, 20 weeks, still continuing to improve. But even after that, if they plateau, they will often continue that treatment, because if they get a flu or they have a bad cold or COVID, or they're just particularly stressed, sometimes they lose some of those cognitive and sleep gains that they get from using the light therapy. So sometimes this is an ongoing treatment that will be done at home. And most of my patients purchase, they don't, rent treatments or devices. So there's no reason why they can't treat ongoing. I mean, I've had patients who have purchased light therapy devices for arthritis, and they've used it morning and night. I know of one of them for well over 12 years. It says a lot about the technology, but it also says a lot about the fact that it's been very helpful. She almost never uses non-steroidal anti-inflammatories or other medications. So it helps her get going in the morning and decreases the inflammation and pain. And then she does it before bed so that she can sleep more soundly without being disturbed when she moves. And there's another question here, wondering about the criteria that's considered when proceeding with treatment to the brain, treating the area of the head injury only, or simultaneous treatment of coordinating areas of the whole brain. So they're asking.
Well, that's fine. It's not a problem. Most traumatic brain injury, I mean, really, it's coup contra coup. So it's both sides of the brain. If it comes in on the left, throw the brain over to the right and it'll juggle back and forth, or front and back. There's most of the time there really is, with traumatic brain injury, it's both sides of the head, and you do end up treating the whole head. It's just fine to do. That's true for traumatic brain injury. It's fine in dementia cases. It should be fine in multiple sclerosis cases too. But if it's only the plaques are on the one side for whatever reason, then you treat the side of the body that's affected, and you treat the side where those hyperintensities are seen on CT scan. And you'd want to work with the neurologist that is taking care of you, and they can tell you if you have the problem on both sides of the head or just one side. It's usually only stroke patients that we fuss over very carefully where we want to put the LED cluster heads on the scalp. And it should be, I think, on the side where the stroke took place, and the patients will always know that. And it's always in your scan report. If they did a CT scan or an MRI, they always do a CT scan in the very beginning. As soon as you go to the emergency room with a traumatic brain injury or even a stroke, they have to know if there's any bleeding in the brain. And if there's bleeding, you can't do your transcranial photobiomodulation until you know that there's no more active bleeding. Sometimes it can take a week or two, and they'll follow that. The neurologist, the neurosurgeon, somebody will be following that if there was a hemorrhage. And you can work with the doctor for sure, explaining what you might want to try to do. And that's
okay. Yeah, I think that makes a lot of sense. And then Diane L., is it possible to treat hyperparathyroidism?
I have no experience with that.
I haven't treated that, actually. I mean, I'm not sure. I know there's been discussion about whether or not we treat the thyroid, even the thyroid. And, I know in Europe they can do that for hypo and hyper, but I don't have experience with that, so I'm not sure. And let me see, 2 new questions down here. Thank you, Jennifer. Where can we find the recording for these webinars? So I believe on the website, you'll be able to find that. And so actually Jennifer is just typing that in. So that won't be a problem. Yes, you can definitely get the videos. And is there a family history of dementia, or if there's a family history of dementia or aphasia? Well, aphasia is usually from a stroke rather than a family history, but can a person use a POM for preventative care? And I think that's what the POM for preventative care. I don't know, Dr. Naeser, if you want to respond or say anything to that, and then I will, but.
I think that is wise, just in healthy aging. you can just treat the default mode network, for example, because that's something that really falls apart in aging, actually. Pretty well known for that. And remember, this mesial prefrontal spot right here in the front is the most vulnerable, but also the most demanding for glucose of areas in the brain. And so as you get older and older, the default mode network gets sort of weaker and weaker. And I think it would make sense to try to at least treat that. I know V-Light has some really good devices for home treatment. And you can do that. And you can do a red and a near infrared nasal, intranasal. I think that would be helpful. It would, as we talked about, I think last time, it would take a long time to do a prevention study. I mean, so 20 years from now, whoever started when they were 50 years old doing this, how are they in when they're 70s? I don't know. But I also don't know anything about the family history of aphasia. That would be related to a stroke. And so that's a different.
I think there's research out there. I mean, I've worked with a number of families where a parent has and had a history. So mom had dementia or Alzheimer's, and her mother had it, and her mother's sister had it. So there's a strong family history there, and it's not going to hurt. And the likelihood that this is going to help is, and just for healthy brain aging, I would see no reason why you shouldn't be using light therapy at some point. And if we look at cognitive processing and students being trained, they score better on test results and have greater memory for what they are learning by using photobiomodulation. So it may not only be helpful down the road, but in fact, you may be cognitively functioning more optimally with the addition of light therapy. So I definitely think that would be worth continuing or considering.
Those papers are published at the University of Texas. And, Hunley, Liu, and Gonzalez Lima, they have wonderful studies with college seniors or freshmen or whatever. I know they're college students, and I think they just put it on the forehead. And they said that they had less anxiety at final exam time. And and they did better. So something to consider.
And then any experience treating Parkinson's is, I think, our last question right here. And yes, there is a fair amount of research out there. We're just completing a study in Hamilton right now. We've been treating transcranially as well as treating the gut and C2. And my clinical results, I can't speak to the research. We don't have the results yet. But in my clinical practice, I've certainly seen great benefit with using light therapy for both motor and non-motor symptoms associated with Parkinson's. And so, yes, that would be something that you would want to look at as treatment, and it's in conjunction with whatever medication. And you can't underestimate, if you're looking at Parkinson's, not only light therapy, the significance and the impact of exercise. And that's not just going out for a walk, but vigorous exercise. And there are exercise programs specifically developed for Parkinson's, and you should look into those as well. That would be worthwhile. And
there's papers published on this too. I mean,
absolutely. Yeah. And we can leave papers on Parkinson's and photobiomodulation and make sure that they're there under the resources here as well.
Yeah, we can send them to Tom Kerber, SunPowerLED.
Yes, so that would be great. I think that's it. I don't see any other questions, Jennifer, unless I've missed something. Yeah, I think everything's there. So
follow up, and we don't know next week. It'll be up to Tom Kerber, and I'm sure that SunPowerLED will post a note.
Well, we will still be having a webinar next week on the 13th. The subject is to be determined, and to those on the mailing list, we'll send you an update as well. So
terrific. Thanks, Sam.
Okay, thank you. Bye-bye.
Have a good night.
Bye.
You too.